guess this is my first research seminar in the department. I joined as a senior lecturer at the start of last year, but it's a nice way of meeting everyone and talking a little bit about the research I'm interested in. So yep, locally grown, so I think I will date myself. Back in 2004, I think I came as a medical student to the clinical school here, trained right up through my physician training here, and then subspecialised in Immuno-oncology. And actually, don't tell anyone, but I only went to Melbourne as the main other place of training. So I was there for 3 years, and actually that's where I met Sharon, our next speaker. And so really struck by the work that they were doing there. So MEDx is like Australia's, correct me if I'm wrong, but their main publicly funded cancer-only hospital with like 13 floors, 7 floors of clinical oncology, and then all the rest of research. So they're really like a translational research powerhouse, as well as many other aspects of oncology care. And I think that's a good intro, because when I finished my training in oncology here in New Zealand, actually the treatments were very limited, and certainly for melanoma, that's a disease where we only had chemotherapy at the time. And unfortunately, New Zealand and Australia, we have the highest incidence of melanoma worldwide. And despite that, our treatments in New Zealand really lagged behind the rest of the world. So chemotherapy, if you've got melanoma in the skin, easy, cut it out. And so that's the majority of cases. But for the patients who have metastatic disease where it's spread to other organs, the prognosis is dire. It's like 6 to 9 months on average, and chemotherapy did almost nothing. You know, it could improve the symptoms a little bit, but not had any survival benefit. And it's really that understanding of cancers, getting to know the molecular markers, molecular drivers, and the oncogenes that drive its growth and metastatic spread, that we actually understood how we could target it. So there was this kind of parallel development of molecular oncogene inhibition of cancers, as well as ramping up the immune system to fight cancers. So both of those kind of treatments happened in parallel, and amazingly, melanoma was like the poster child for this, and has really led both of those treatments to be really the driver in all the other cancer types, actually. So real revolution in the treatment in terms of targeting the MAP kinase pathway, the oncogene pathway, as well as the immunotherapy, which I'll talk in more detail about. I'm going to name my patient John. John came to see me as a new fellow at the MEDx, and I was getting ready for my usual New Zealand spiel of how it goes and what it looks like for people with melanoma. And this is an FDG PET scan, so that's functional imaging of how metabolically active tissues are. So brain being very metabolically active is dark there, and there's uptake normally in the bladder, that's normal. But you can see that right around his liver, and also up in the mediastinum, is covered in very metabolically active hot nodes and metastatic cancer. So his cancer was everywhere, really. He enrolled in a clinical trial, and so in Melbourne I was really swept away by this, all these clinical trials that were happening, particularly for immunotherapy, and within 2 cycles of treatment his cancers have started melting away. And what's really unique about immunotherapy compared to, say, chemotherapy is that the durability of response. So this is his PET scan, a couple of months after treatment, and then this is the PET scan 5 years down the track, showing absolutely no cancer on his scans. Whereas, say, for chemotherapy, even if it worked, it would work for a few months, but not really get that durability. And we have now 2 funded immunotherapy agents in New Zealand. This is the anti-PD-1 or anti-program death 1 monoclonal antibody. It's publicly funded, and that funding is really important because most of the cancer drugs that we use that are not funded is about $10,000 a dose. So it's huge financial cost. And so that's one part. There are two main drugs that target melanoma that's been shown to have a good long-term response. The first is the anti-PD-1 that I just talked about that's available in New Zealand. Actually, that's the second group of drugs that are shown to be effective. The first drug was targeting another part of that immune pathway. So that's the anti-CTLA-4. The CTLA-4 and PD-1, they're just immune checkpoints, so natural inhibitory checkpoints in the immune pathway. So in brief, the immune system, you see the immune system like a ADC or antigen presenting cell would recognize a foreign antigen or even an antigen from the cancer, and then you want it to activate, proliferate, recruit other immune cells, and then you want a natural way of shutting that immune system down, right? So you need an inhibitory, an off switch. Once you've turned it on, you want it off as well. And so our body naturally would have these inhibitory molecules to switch down, dampen down the immune system. But what we're doing with our drugs is actually monoclonal antibodies that block the off switch, so thereby ramping up the immune system and letting it be reinvigorated and have attenuated action, right? And so what we found was that the first drug, that anti-CTLA-4, had that durable response in metastatic melanoma in about 20% of patients. And compared to anti-PD-1, actually the second drug is even more effective. About 40% of the treated patients had a durable response. And of course, as oncologists, we love combining drugs. If they worked well singly, we want to see if combining them would make them synergistic or work better. And that's exactly what we found, so that the ipilimumab or anti-CTLA-4 on its own, about 20%-ish, and then PD-1, about 40%-ish, but when you combine them, it lifts the response rate even higher. But the downside, and there's always a downside, is that once you've activated the immune system hard, you also get autoimmune conditions, right? Immune-mediated adverse events or side effects. And you can see in the blue bars there, these are immune toxicities in the various organ systems, and the blue is the anti-CTLA-4, whereas the yellow is the PD-1. And you can see that the CTLA-4 on a whole has higher toxicity than PD-1. And when you combine them, that's even worse, you know. So you're, for PD-1, it's about 15% have life-threatening toxicities or severe toxicities, whereas anti-CTLA-4, it's about 40%. When you add them both, it's about 55%, so much higher rates. And then most of the toxicity, and this is what I teach the medical students, usually we see them starting within the first 3 months of starting treatment, but actually it can happen anytime. And even some of the case reports are reporting people having toxicities 2 years after stopping the treatment. So of course it's very important for all the other, not just oncology doctors, to know about the toxicity, but for other medical clinicians to do that. And so what really struck me was this, you know, you have John on one hand, where he's had an amazing response to immunotherapy, and then I'd treat other patients in the clinic where that response was not seen at all. The cancer just romped through as though you'd done nothing. And so I was really interested in biomarkers and trying to find a way of predicting who will respond and who wouldn't, because that way we can select the group of people who would really benefit from the treatment and then save the rest for either finding more effective treatments in that group or saving the money, right, and the toxicity. And so particularly as you can get lifelong toxicities involving potentially any organ of the body. And so this is a, I guess, schema or framework that was proposed by Portume, one of the key researchers in this field. And I think it's just to demonstrate that the immune system's a complex beast, right? There are general immune status factors that really helped us predict whether the immune system is going to be activated or not. One of the key, I guess, observations in melanoma space anyway is that actually the presence of intratumoral T cells or evidence of activation of the immune system in tumour biopsies prior to treatment, that's a really, in multiple cancer types actually, has been observed to be a really good predictor. But invasive biopsies, that's hard, right? And we know that it can cause complications getting biopsies, so it's not really that practical. You hear a lot in the oncology space about the PD-L1, because remember that immune system, that checkpoint that we were trying to unleash was the PD-L1 pathway. And so actually if you see a lot of this checkpoint, the PD-L1, that's a predictor in some cancers like lung cancer. That's a predictor of good response as well. But that's very highly variable, very heterogeneous, changes with time, changes if you biopsy different parts of the body. So it's a problematic biomarker. And then there are more easy to measure biomarkers like IL-6 or the C-reactive protein. That's to demonstrate that it's where the response is less seen. And then other things that people look into is because you need if you have more of the tumour antigen, you have more of the tumour mutational load, that also correlates with a response. And that kind of makes sense, right? You've got more of the antigen around, there's more for the immune system to pick up. And so in the melanoma space, there were some well-recognised prognostic markers. And very sensibly, if the further the spread of cancer, the worse the outcome. So people with brain metastases, poor outcome. This is a group that we'll come back to, and I was really interested in that. So I looked into that as part of my PhD, but we're trying to do some work in that space now. And then, of course, there are a number of markers that I just talked about from the previous slide that was also associated with response. During my PhD, I really loved collaborating with members of other teams. And so here are two palliative care physicians from the PMAC, and we really looked at, kind of controversial at the time, and I don't know if you remember some of our conversations, Sharon, but so with chemotherapy, we know that your baseline fitness, the patient's baseline fitness is a really good prognostic indicator. If you're in bed for more than half the day, it's highly unlikely you'll respond to the treatment. And it's more likely you're going to have toxicity and worse outcome if you didn't, compared to if you didn't get chemo. But because the immunotherapy was such an exciting treatment, this holy grail, so everybody was like, get your patients onto the immunotherapy, they must have it. And so we asked this kind of, at the time, ridiculous question, but that same question of, if your baseline fitness, does that correlate with effect, with outcome? And we found that people who had poor baseline fitness, shown in the red, had a terrible survival despite getting the immunotherapy. It didn't really have this Lazarus effect that everyone was hoping for, right? And now there are prospective smaller studies that look into it. But it's a difficult group to try and, of course, recruit into clinical trials because their patients are so sick. But it sort of gave us a really good starting point to do more palliative care research in the patient group. Peter Mac is also known for its functional imaging, so I spent a long time looking at PET scans, those functional scans that I was looking at before, and we found that if you had really small burden of disease, so very small metabolic tumour volume, your outlook is much better than if you had lots of disease. And that sort of makes sense, right? You're less immunosuppressed to begin with from all that metabolic tumour burden. But what was really interesting, I thought, was that, well, we look at the whole body, and actually there is this, and there's all these interest in trying to find ways of measuring the immune system, right? And so I looked at the spleen and the functional uptake of the spleen, and to see whether that would predict for response. And surprisingly to me, that actually if you have a really high splenic uptake indicating inflammation, that actually had a really poor correlation with a response. And patients who had high splenic uptake actually died very quickly. And that's seen in other cancer types as well, but the main work is in melanoma. But yeah, we managed to collaborate internationally, so we looked at the Australian cohort as well as people from Brussels and Zurich. So, and then the last, I spent a year in the lab looking at tumour profiling by different methods, looking at multiplex immunohistochemistry and RNA-seq, and got involved that way, just comparing different cancers. And it was really interesting when we compared different cancers, actually comparing melanoma with squamous cell cancer and Merkel cell cancer. We find actually the Merkel cell cancer had a very different immune system and different cells being activated. But coming back to the brain mets, actually, just give an overview of what we're doing. So I guess this is to showcase what kind of research we're doing currently. I was really interested in applying the real world data because the work that I was doing with the palliative care team showed to me that we can't just go off clinical trials all the time. The patients that we see in our clinics with their multiple comorbidities, their poor fitness, all of these patients are excluded from the clinical trials. And particularly for brain mets, that was a big part as well. But it showed to me that it was really important for us to collect our own data and collect and know what is the treatment like in our hands. And so that drives a couple of projects that we've had going in the department with our registrars. So we looked at different ways of monitoring for immunotherapy. We collaborated with the Waikato cohort, and I'll show you the data from that. There was a derm trainee who was really interested in derm toxicity, so we're doing that. Some of our registrars are interested in outcomes in older patients and whether that would affect the outcome. And then so firstly, this is Dr. Eric Zhang from Waikato. He's a GenMed trainee, now a consultant there. He and our trainee, Dr. Amrit Singh, looked at 5 years of treatment for patients with melanoma and looked at their toxicity rates. And I was terrified somewhat to find that the Waikato toxicity rate for anti-PD-1 was only 23% compared to the Wellington one of 63%. But because our trainee who looked at it was really interested in derm, he scoured through the notes for every indication of rash. So actually, once we looked at just the severe toxicities, our rates were quite comparable, but it highlighted, I guess, maybe the poor documentation of derm toxicity management, across the board. But yeah, overall, and I think this is interesting, but I would be really cautious in its interpretation, is that we found that people with toxicity tended to have better survival and better outcome compared to people who didn't experience a toxicity. I am somewhat cautious about how you interpret that because there's mortality bias, right? So if you were doing well and you stay on the treatment for a long time, you're going to accrue more toxicities. So I think even though this kind of correlation has been seen in lots of other retrospective data sets, I think, yeah, I'd be cautious about that. But it is definitely an area of interest for not just immunotherapy oncologists, but for the field about whether there are predictors of toxicity and how that correlates with outcomes of interest. This is our work on brain mets, and I'm really proud of our summer student Neve, who was in our department over the summer. She is super enthusiastic and really enabled us to do a national audit, and that's the first national audit in our space anyway for immunotherapy and melanoma. And she wanted to ask this particular question about people with brain metastases. Why? Because in New Zealand, like I told you, we only have that pembrolizumab or nivolumab funded, right? The anti-PD-1 agents. It's not as effective. We don't have the ipilimumab, the anti-CTLA-4 agent funded. That's because it's very expensive. It's about $100,000 for 4 doses, right? And so when you have, but in prospective clinical trials, the combination is much more active. And so internationally, that would be the standard of care for patients with brain metastases. And so we set out to ask the question, are we lagging behind? Is that a huge difference, you know? And actually, secretly, I think I was thinking that my hypothesis was that we would be having poorer outcomes as a result, right? And that would be a good way of advocating for our patients to get better treatment, to have the data. So I sent Neve on a little road trip around the country, visiting all the different 7 major cancer centres in the country and working with all the different oncologists. So I think it was a good experience for her too. And so she found some really interesting results. So there was 144 patients treated overall, with a 4-year follow-up. And the patients treated are kind of representative of who you'd expect. You know, elderly patients who mainly Caucasian. Most patients had more than 3 comorbidities, more other illnesses. About a third of them had high LDH, which is a prognostic marker for bad prognosis. And then actually, interestingly, about a quarter of patients had poor baseline prognosis. And this is the crux here, is that actually most of the patients had symptomatic brain metastases. And even the prospective clinical trials that that guide us either excluded people with brain metastases or they only recruited people with asymptomatic brain metastases. So this is where there was real paucity of data. And basically when we read the papers, we're like, these aren't the patients that we're treating. These aren't the patients we're seeing in our clinic. Our patients don't get MRIs every 2-3 months to pick up asymptomatic brain metastases. They just present to the emergency department because they've had new neurological symptoms. This is the spread of the different centres that were involved, but mainly driven by Auckland data, but it was good to get representation from the South Islanders as well. And so, as we'd expect, 92%, most patients had just PD-1 on its own, and only 11 patients in the country were able to self-fund the world standard of care, right? And a third of patients had steroid use, again another thing that is exclusion criteria for trials. And about half the patients had some form of local therapy prior to starting the immunotherapy, so be it surgery or radiation. They're really fancy with their radiation now, so instead of the whole brain radiation that I started with when my oncology training, they can really do targeted stereotactic specialised radiation to just the brain metastasis. So this was a real surprise to us, was that actually a third of patients were alive long term, years after, with just PD-1 alone. And I think I was really surprised. If you look at international data sets, usually the quoted would be 10% would be alive. And I think that's really important data for us to have, because it really helps us talk to our patients, helps us recognise the gap, because we only found that about a third of patients were asymptomatic at their last follow-up, and so 2/3 of patients actually had quite debilitating neurological symptoms, and so that sort of opens up an area that we actually need to focus our mahi on. Luckily, the toxicity rates are similar to prospective studies, and I think this is in some ways I guess reassuring for me that when I push for my patients with brain metastases to have surgery or radiation, that we're not actually just, there are patients who have long-term survival who would benefit from that. Probably going way over time, but just briefly, we're also doing quite a few clinical trials. We're doing adjuvant studies, so of course when it's such an effective treatment in the metastatic space, we want to move it earlier into the disease course so that if there's locally advanced disease, people who are likely to relapse, we want to find out is it possible to give a bit of treatment as adjuvant to prevent relapse. And then now, even more courageously, we're looking into the near-adjuvant space. So the tumour's still there, so lots of tumour antigen around. We give the immunotherapy then, before the surgery, and that is a great, I guess, in vivo model or living model of assessment of is the immunotherapy working, and can we then substratify who actually benefits from further adjuvant treatment and not. And potentially it could reduce the amount of surgery we need. So that's hopefully going to be what we apply for an HRC grant the following year, but watch this space. Yeah, so I'm collaborating with some experts in Sydney now, looking at the neoadjuvant space. So yeah, Tristram's slide. Impacts from research, I think, hope I've shown you that oncology research in this space is really meaningful. It helps our trainees, it builds the capacity of our team, both in the clinical trials as well as real world data. And it's enabled us to have collaborations both nationally, which is great, as well as internationally. In terms of output, we're able to present and publish our work. And I really hope that having that real world data helps us have a meaningful conversation with our, pharmac and drug approval, but also not just drugs, because I know oncologists always, we're all about getting expensive drugs for our patients, but actually what is the gap? What is the functional gap, and how do we improve the quality of life? So yeah, that's it.